Good evening. It's just great to see so many of these hardy people who came out in the rain to join us tonight for Medicine in Our Backyard. So I'm pleased to welcome you here. This is a series that's presented by the Newport Beach Public Library Foundation in partnership with UCI Health. My name is Adrienne Windsor. I'm a board member emeritus of the foundation, but they let me keep doing these introductions, which I enjoy so much. So we'd like to thank our generous sponsors, Mike and Polly Smith. They've been with us since the initiation of this program. And we would also like to thank UCI Health for their sponsorship and for bringing all these wonderful, wonderful practitioners to us once a month to speak to us. I would also like to acknowledge someone in the back of the room. Kunga, would you wave? She greeted you when you walked in. Kunga Wagmo Upshaw, she is our program director and she coordinates for the foundation. Jane Merritt isn't here tonight, but she does it for UCI Health, and they've been doing it for years and they do it so magnificently. So we are very, very grateful. Now, a quick bit about our foundation. This is a membership-driven organization, and our mission is to support the library and fund library resources, services, and stimulating programs to the community. How many of you are members of the foundation? Quite a few. If you aren't, I hope you consider joining tonight before you leave. We do so much to support the library. The Media Center we founded, we put computers upstairs. A good part of the ebook collection has been donated by the foundation. And the foundation has just recently made a commitment to raise half of the funding for the new lecture hall, the Woody Lecture Hall, that was approved by the City Council on January 9th. So this is a magnificent effort that the foundation is putting forward, and when you become a member, you will be a part of that. You are also the first to learn about our Woody lectures and our Library Live lectures. I noticed Janet Hadley. Janet, would you wave? Is here tonight. She's the chair of our Woody lecture series, and we have our first one on Friday night, totally sold out. So please just become a part of us. We're happy you're here. We want you to keep coming, and we want you to come frequently and often. Now, a few reminders. This program will conclude with Q&A, so we request you hold all of your questions until the end. And then I will be coming out with a microphone, and you will be able to ask your questions at that time. Also, please remember to silence your phones. So I am pleased to introduce tonight's speaker, Dr. Marjan Farid. Dr. Marjan Farid is board-certified UCI Health ophthalmologist who specializes in cornea, cataract, and refractive surgery and the treatment of ocular surface disorders. How many of you have had your cataracts replaced? Just out of curiosity, so that Dr. Farid will know. Dr. Farid earned her medical degree at UC San Diego, followed by an internship at Scripps Mercy Hospital in San Diego. She completed her residency in ophthalmology at UCI here at the university, and she also received fellowship training in cornea and external disease under the late Dr. Roger Steinert, an international pioneer in refractive laser surgery. Now, I have to tell you a story about Dr. Steinert. This program actually was initiated in his office at a small luncheon where Mike and Polly Smith attended. I happened to be there. I was lucky enough to be there. And after he talked to us about his laser surgery, we said, wouldn't it be wonderful if we had something at the library where we could bring this resource to us? And that is how it started. It's more than a decade ago. So it's just wonderful to have Dr. Farid here tonight to bring this whole experience full circle. So please join me in welcoming Dr. Farid.
Thank you so much for inviting me, and it's such an honor to be here, and especially after hearing the story of all of this sort of starting with Dr. Steiner, who was my mentor, and really I owe so much to him in terms of what I do and my practice, so it's very special to me. Thank you so much for having me, and welcome, and amazing you all came out in the rain. I was worried I would be speaking to an empty room, and it's completely full, so thank you so much for being here. I thought we would just start with this discussion on cataract surgery, what's new in the field. There's, when I see my patients in the office, there's always so much ambiguity on what does it mean that I have a cataract. I thought you only had cataracts when you were like 80s and 90s. That's not the case. What does it entail? And what's the new technology? Because this is such an advancing field. And then the other topic here, dry eye disease, which almost everybody in Southern California has some degree of dry eye, and also in this age of increased screen time, being in front of a computer all day and our cell phones and such, everybody has some degree of dry eye. And these two things matter together, because if you have dry eyes and if it's significant, it can impact the success of your cataract surgery. So they go hand in hand, and that's why I sort of threw these two topics together, because they really go together. But let's start with cataract really quick. I have a lot of slides, and we're not going to belabor a lot of things, but I'll just try to keep it going because I want to save a lot of time for questions. What is cataract? Why does it form? Who does it impact? Driving is a huge factor here in patients who have cataract surgery. The first question I always ask my patients is, do you have glare at night when you're driving? And that's one of the earliest symptoms of cataract. So that's really important, because if you do, then we might not want to wait until the cataract is more severe, because safety is an issue when you're driving. The process of cataract surgery, who's a candidate for what technology? I want to talk about that too. And then post-operative, what does the post-operative case look like? So the cataract is basically the lens of the eye. The lens is in the center of the eye here. And when we're young and kids, that's a beautiful clear lens. It flexes nicely, so we're able to see distance, we're able to see near. It works beautifully. Right at the age of 40 is when this lens starts to stiffen. And that's when we notice what we call presbyopia. The reading becomes more difficult because that lens can't squeeze as much as it used to. It becomes stiffer. And so our arms start getting longer and we start needing reading glasses. That's sort of the beginning of cataracts. And patients are like, oh, really? At the age of 40? Yeah, that's sort of the beginning of it because it gets stiff. Now, as we continue to progress, cataracts becomes opacified. Let me just show a picture, and it can turn into something like that upper picture, which is a central polar cataract. This is a very, very severe cataract down here where it's totally white. We see that sometimes with trauma, if a trauma is involved, but that's sort of the more severe stage. But what causes cataract? Really just age. It's not a disease. It's a normal aging of the eye. It's a natural clouding of the crystalline lens. It causes poor focusing, scattering of light, and that's why we get glare at night from oncoming traffic lights. Other risk factors, diabetics tend to get cataracts a little bit earlier. Trauma, as I mentioned. If you've been on medications like steroids for allergies, for example, even nasal steroids can sometimes cause the progression of cataract a little bit faster, or extensive exposure to UV light. And again, glare is one of the early symptoms. Some patients will say I have more trouble reading in dark or dim light conditions. That's also the early start of a cataract. Contrast goes down, so that time between when the sun is out and when the sun goes down, the contrast starts getting worse, being able to distinguish shapes. 1 out of 3 patients have some visual loss by the age of 65. And in a lot of cases for elderly patients, it could cause a loss of independent living, mobility issues, falls, fractures, isolation. Cataract is the 3rd leading cause of visual loss in the elderly in the United States. And it's a public health issue. And I'm going to jump over some of this to just this this study that was done in 2002, where they looked at cataract surgery, basically reduced the risk of car crashes by 50% in the elderly population. So it's really very impactful. And so, you know, I tell my patients, if you're starting to have those symptoms, there's no reason to wait, because the technology is so good. It's such a different time. Cataract surgery is done quickly. You're back to your daily routine quickly, and it's very safe, and the benefits far outweigh the risks in most cases. We do like to make sure patients are healthy before surgery. The anesthesia is minimal. We use what we call light sedation for patients. Of course, the eye is numbed. And so we do have patients go through a little bit of a cardiovascular clearance, but really you don't have to come off things like your blood thinners. A lot of patients ask me that. It's really a bloodless surgery. And we like to know what glasses you're in now. What is your ocular history? Have you been nearsighted all your life? Have you been farsighted all your life? Are you used to wearing contact lenses or not? What does the rest of the health of the eye look like? What does your optic nerve look like? What does your retina look like? Is there macular degeneration or glaucoma? These are all things that are very important in my assessment when I see a cataract patient. And no two cataract patients are alike. So a lot of patients will come and say, well, my friend had this lens and they're loving it. I want that lens. Like, wait a second. You have a different set of eyes, a different brain. A lot of the intraocular lens technology we use, there's a neural adaptation that goes along with those. So everybody's different. Their eye health is different. Their visual requirements may be different. So each patient is, we try to tailor the specific cataract surgery and the technology to the patient. So as I mentioned, most of these are performed under just local anesthesia, so you're kind of awake, but in a twilight. I only use general anesthesia in children, or if patients have maybe severe claustrophobia, because we do put a drape over the eyes and face, or if they're unable to lie still for some reason. Surgery in my hands is less than 10 minutes. Really, it's very, very quick, but in general, 6 to 15 minutes. Again, you don't need to come off of your blood thinners. And so what we do is we make these tiny incisions, a 2-millimeter incision. We do what's called a capsulorhexis. We open the skin around that lens. And then we use what's called phacoemulsification. It's a small needle. There's ultrasound energy at the tip of that needle and vacuum power. So we chop up the lens or the cataract and we suction that out. And then what we do is through that same incision, we taco fold or a taquito fold of an intraocular lens, and we insert it through that same 2.5-millimeter incision. It sits where the natural lens used to sit within this capsular support bag, and there it is in the eye where the natural lens used to sit. And it sort of is inside the eye. You don't feel it. Some patients will say, well, I kind of feel my eye after cataract surgery. Is that the lens? No, the lens is inside the eye. What you're feeling is probably the dry eye that gets a little worse after cataract surgery, and we'll talk about that as well. So here's a video, short one. I think we've sort of got, so you can sort of see what it, if you're squeamish, just look away. If you're interested to look, please look. So we use a little bit of a gel inside the eye. We use numbing medicine inside the eye, and that's what you're seeing. We're sort of squirting inside and outside of the eye. We use what we call viscoelastic gel. That's the gel we're filling the front of the eye to keep the eye formed. There's that 2.5-millimeter incision. So there's two incisions, a 2.5-millimeter incision and then a 1-millimeter side port incision. Here's, we're forming this circular, what we call capsulorhexis. We're basically peeling the skin of the front of the capsule so we can get to the lens. And we try to keep that capsulorhexis centered and circular so that it doesn't run out and hold the lens at the end of the case. So that's probably, some people call that the most difficult part of the surgery. But and then we use a lot of water. A lot of this is done underwater. We use water to loosen up the lens within that capsular bag. And there's my phacoemulsification needle. We introduce that into the eye. We have a little second instrument, what we call a chopper. And you'll see us sort of chopping this cataract. And you're going to see us doing that. Here it is. There's one nice big chop. So now it's in two big pieces, two big hemispheres. And then we'll chop it a few more times, kind of like cutting pieces of the pie, right? We're cutting it up. And now I push down on my pedal, foot pedal. So now I'm starting to suction, and you can see suctioning that cataract piece there. So that's a little piece of, so some people also say, can I see my cataract afterwards? I'm like, no. We've broken it up, we've chopped it up, we've vaporized it, and we've sucked it into this bag of water. So there's nothing to see afterwards. Gone are the days when we used to make 12 millimeter incisions and take the whole thing out in whole. We don't do that anymore. This is the last bit, what we call the cortex around the lens. This is the outer part of the onion. If you think of the cataract sort of as an onion with lots of layers, this is the outer layer of it that we're peeling now. There's still a bag intact, and the bag is nice and clear. We refill it with that viscoelastic or gel to just keep it formed. And finally, we put in an intraocular lens. You can see we're rolling it. It goes through this sort of injector system, and it comes out as a roll, but then it unfolds within the eye. And so we're going to start injecting that in here. You see the little foot, what we call the haptic, go in first. And here's the optic, and there's the trailing haptic. So the optic, you're seeing it unfold right there. So we'll go ahead and position that trailing haptic in. We'll center that lens, and we're done. So we take out the gel, that's the last bit. And 90% of these don't need a stitch. That wound, that 2 millimeter wound is self-sealing. So we hydrate it. We hydrate the wounds, and they sort of get fat and stick together, and they're self-sealed. And that's it. That's cataract surgery. So let's talk about lenses, because this is the fun part of cataract surgery is we have so many lens options now. We have what you saw right now was a standard monofocal lens. A monofocal lens has a single focus. So I ask patients, well, do you want me to set you for near or for near vision or distance vision? Some patients who have had contact lenses and have done one eye for distance, one eye for near, something we call monovision, if their brain is used to that, then I say, okay, I can give that to you. But if you're not used to it, I hesitate to suddenly give somebody monovision because you can have a little bit of depth perception issues that way. But that's what we can do with a monofocal lens is we can either do distance or near, and then the patient has to wear glasses for the other. But this is a very common option, and sometimes the only option if there's other ocular comorbidities. So if you have macular degeneration, for example, or severe glaucoma, then some of these other lens technologies might not be the best candidate. So the monofocal lens are really our fallback. They're good for everybody. Okay, then we have our lifestyle lenses. These are to really decrease dependence on glasses. So we have multifocal lenses, extended depth of focus lenses, light adjustable lenses. Toric lenses are astigmatism correcting lenses. So this is actually a video. You can find this online. So it goes through when we have a healthy eye, we can see distance, intermediate, and near really well. Presbyopia is when we hit 40 and you can see the near gets blurry, right? Now, when cataract develops, we lose contrast. This is more of a severe cataract, and things get blurry everywhere. Now, this is a monofocal lens set for distance, so you can see the distance is clear, the near is blurry. This is a multifocal lens that can give you distance, intermediate, and near. But the multifocal lenses will give you these halos at night. And so you see the little halos? So they give you distance, intermediate, and near, but the side effect of these multifocal lenses are these halos. So, I mean, you can't get back to what God gave you when you were young, which is seeing everything absolutely perfectly with no side effects. We don't have a lens for that yet. But these are what the multifocal lenses look like, or extended depth of focus. They've got rings on them, and that's what translates to the halos at night, right? That means they're doing their job. But if a patient is a truck driver and drives at night, I'm not going to do a multifocal lens in that eye. Most of these lenses, newer versions, newer models, because these constantly are getting, improved. The current upgrades, really their side effect profile on night halos is less, but it's not zero. So I feel pretty comfortable. My brother-in-law, for example, I put in what we call the Symphony lens, which is this first lens here, which gives you really nice distance, really nice intermediate. with very little halos, not zero. And he drives at night all the time. And I say, well, are you seeing the halos? He goes, well, if you ask me, yes, I see them. So don't ask me, because he's used to them now. Like, don't ask me, because I don't usually, it becomes your normal. And that's what you call neuroadaptation, right? So it's that brain learning to sort of ignore that halo around the light. So there's different versions of these, and I'm not going to jump into all the different versions. Let me go back here. But some do great distance intermediate, some do distance intermediate and near. The ones that do give you the most, give you most halos as well. So there's that trade-off. And the ones that give you the least halos give you some range, but not necessarily full range. So that's our trade-off. There's a cool new lane. It's not new. I shouldn't say it's new. It's been around for a few years, but the newest upgrade to it is the best one, really, that's been out there. It's called the light adjustable lens. This is the only lens where we put the lens in, and afterwards, after cataract surgery, we can adjust the power of the lens depending on the patient's desires. So what we can do is, for example, start you out with distance in both eyes, and then after surgery, we can give you a little near in one eye. If you like it, we can give you more near. If you don't like it, we can go back. So we can do a little bit of this adjustment until you're perfectly happy with it, and then we lock it in. There's a little bit of a process. You have to wear these sunglasses for that period until the lens gets locked in, and that's somewhere between 6 and 10 weeks. But this is a really cool new technology that works really well, especially if you've had LASIK in the past. The patients who've had LASIK in the past, their lens power prediction is not quite accurate with our current formulas. And so this allows us to adjust our power afterwards and get you perfectly there. What about astigmatism? So astigmatism just means the cornea, the front window of the eye, is a little more football shaped. It's not a perfect sphere, it's a little more cylindrical. You can have astigmatism where the cornea is more steep in the 90-degree axis or in oblique or at 180 axis. This is irregular astigmatism. This one we can't really correct well, but astigmatism we can correct with surgery, also with the lenses, toric lenses. This is a new lens. It's called the pinhole optic lens, or IC8. Apthera is the actually manufactured name for it now. Have you ever looked through a pinhole and noticed, wow, everything is suddenly sharp? This is utilizing that pinhole optic effect. It's basically the black rim is tuning out all of the defocused light, so you're only letting in the focused light, and it increases your depth of perception. So this lens we can put in the non-dominant eye to give patients a little more depth and a little more range without giving them the halos. This doesn't give you the halos. So this is another tool in our toolbox, good for some patients. It does help with some irregular astigmatism as well. So this is new on the market as well and works in some patients nicely. What about laser cataract surgery? So the surgery you saw me show you the video of did not include laser. There is laser technology now, and so a lot of patients say, well, what is that? What is the addition of that? Well, the laser does a few things. It softens the lens. So if the lens is very, very dense, it softens that so we don't have to put in as much energy into the eye, and so the recovery is a little faster. But the other big thing it does is it creates these relaxing incisions on the cornea to decrease astigmatism. So you can treat your astigmatism as well. It also helps with lens centration. Let's see, here's a little video to show. It basically creates a lot of precision. It uses OCT imaging to actually image the entire front part of the eye. And you can see that here, optical coherence tomography. It uses images so we can see where the front of the cornea is, where the back of the cornea is, where the iris is, where the lens is. So all of this is calculated under the laser first. And then based on where all of the anatomy of the eye is, then it puts the laser shots into the cataract, into the lens, and into the cornea to create those incisions for us. So it's just so super cool, and it makes things very high tech. Let me jump over this one for the sake of time. So this is what the eye looks like under the laser. Is this a video? I think it might be. Okay, maybe not. So we can see the entire lens. Now here you can see the laser has already occurred, and you can see the lens is almost pre-chopped for us. So less chopping is involved. But it's also made relaxing incisions on the cornea, which are harder to see on this video. You can see we're just completing those chops like a pie, and again, pulling out each of those pieces of cataract, leaving those up. So it adds this extra precision. All right, what happens after cataract surgery? You go home with a clear shield or no shield. You can use the eye right away. You don't need to have it covered up. And we do start eye drops right away. So we start antibiotic eye drops, anti-inflammatory eye drops. Those are tapered off over about 4 to 6 weeks. Limitations, I tell patients don't lift very heavy for about a week after surgery. And if we're doing the 2 eyes a week apart, which is how I usually do it, then it's 2 weeks. And not a lot of bending, no yoga, no Pilates. I have patients sleep with an eye shield on for the first week, just so you don't poke yourself or push into the pillow too hard. And we usually see the patients the day after surgery, and then in a few weeks, and then in a few months. So it's not a lot of post-op back and forth. Unless you're getting the light adjustable lens, then you're coming back and forth to adjust the power of the lens. Success rate is very, very high. It's higher than 97%. That 3%, there are some patients and some diseases that make cataract surgery a little higher risk, but for the majority of normal eyes, it's a very simple procedure. In complications such as infections, very, very rare, 1 in 10,000. Really, it's a bloodless surgery. Again, you don't need to come off of your blood thinners. What is very, very common is that capsule that surrounds the lens, and we put the lens in there. That membrane behind the lens gets hazy over time across the board. We call that a posterior capsular opacification. And somewhere between month 6 after surgery and year 6 after surgery, we do an in-office 1-minute laser procedure to clear that posterior capsular opacification up, and you only need that done once. So cataract surgery is the most common surgery performed in the U.S. Return to normal visual function and activity are very quickly achieved. You don't need a big, long chunk of time off from work. Risks are very, very low, and you don't need to wait for your cataract to be ripe. That was back in the days when they needed to make a 12-millimeter incision and take the whole thing out. Now, the softer it is, the easier it actually comes out. And lens options and laser options, I really tailor to your eye. So it's not one size fits all. It really needs to, that discussion is the longest part of my preoperative evaluation with each patient to decide what is the best lens for their eye or whether laser will help them or not. All right, I'm going to jump into this patient that I saw who came in for cataract surgery. She wanted cataract surgery. Her friend had those fancy lenses where she didn't have to wear glasses, super excited. And she said, I'm having poor night driving vision, but also my vision at the end of the day gets worse. It starts out okay. I start out reading okay, but then it gets worse. That's my cataract, right? No, cataract is bad all the time. If it's fluctuating, if your vision is sometimes good, sometimes bad, you may still have a cataract, but that's not from the cataract. That fluctuating vision, there's only one thing that does that, and that's tear film dysfunction, what we call dry eye disease, which is really a bad term for it because dry eye implies put a drop on it, now it's wet and it's fine. It's not. It's really tear film dysfunction. We asked her, how do your eyes feel? She says, fine, which also really supports this, that a lot of patients who have dry eye disease don't know they have dry eye disease. Their eyes feel fine. They don't necessarily feel dry. But when we look at the surface of her eye and we put that green stain on it, look at this cornea. It looks like sandpaper. It's terrible. It's lighting up. This is severe dry eye disease. When we look at the oil glands along the base of her lashes that produce the oils that go into our tear film, they're all clogged up. You see them? They're all little white. It's almost like little white pimples. Sometimes they're so severe that it's not white anymore and they produce no oils anymore. So this is a very, very severe ocular surface or dry eye disease. Well, if you have severe dry eye disease, it can, and you come in for cataract surgery and nobody catches that you have dry eye disease and you just go on with the surgery, well, the measurements that we use to determine the power of the lens that go into your eye can be wrong. What we call your topography, your keratometry, your refraction, all those measurements that we use to determine the lens power are wrong. And so I have a lot of patients that come to me after cataract surgery and their lens power is off. What happened? Did the doctor make a mistake? Well, no, not really. The cataract surgery went fine, but the eyes were dry when they did the measurements, so they had bad measurements. So the lens power that got into the eye is not quite accurate. It also, dry eyes, DED, dry eye disease or ocular surface disease, increases the risk for surgical infections. Dry eye disease gets worse after cataract surgery because of the preserved drops we use on the eye. So if you don't treat it before surgery, you might go in, you might not even know you have dry eyes, and now you come out of surgery unhappy, and now you know you have dry eyes. So I see this is a lecture I give to my colleagues all the time on the importance of looking for this before jumping into cataract surgery. This is a study that was done that showed 60% of routine cataract patients who came in just for cataract surgery, no symptoms of dry eyes, no pain, no burning, no irritation, but when we stained their cornea and looked for the signs of dry eye disease, 50% of them had what we call central corneal staining, which means they had all these dry spots across the surface of their cornea, which would have led to poor biometry and poor measurements. So very, very important. So how do we look at the surface? So I want to show you this video. It's a little bit gross, but the oil glands, because I talk to my patients about oil glands all the time, and it's like, what are you talking about? You know, what do you mean by oil glands? The oil glands are along the base of the lashes. This is an epidemic. It may have something to do with our diets in this country. I don't know, but it's an epidemic. Those oil glands are clogged. We should have olive oil consistent oils coming out of those oil glands. And in many cases, many of us here in the audience, including myself, those oils have turned into butter or toothpaste. And so they don't express well into the tear film, so our tears don't have the oils they need to have. And so we get dry eyes because our tears evaporate. Our tears need a good, healthy oil layer, and they won't have that. So here what we're doing is we're going to squeeze these oil glands here in the clinic with a little paddle. The patient has been numbed. And you can see when you squeeze it, look at all that toothpaste that comes out. These are not healthy oil glands, right? You couldn't tell when you looked at it. I look fine, right? But that's what's clogged up in there, and you can't get those really severe. Anyway, she has it in both eyes. This is very, very common, by the way. So how do we assess? Well, there's some tools we can use. We can look at the osmolarity of the tear film. We can look at inflammation in the tear film. We can look at something called meibography. This is not X-ray, it's just using lights to assess the oil glands. Here are healthy oil glands. Here are oil glands that are almost completely gone. You just see little nubs here. You see a little bit here, a lot of oil glands missing. And this is very common. We see this. Aging has something to do with it, but also diet, computer screen time, makeup, contact lens wear. All of these are risk factors for what we call meibomian gland disease. So what is my goal when I see a cataract patient who has dry eyes? Well, I don't want to delay too long, right? And sit here for months and months and months and treat the dry eyes. Sometimes we have to in the severe forms. But I want to reduce the surgical delay time. We want to try to turn around that tear film layer quickly. So we do that with what we call a multifaceted approach. So I use a lot of things, and sometimes it can be a little overwhelming because you come in for cataract surgery and here your doctor, me, is telling you all these millions of things you have to do to improve your dry eyes first. And you're like, what? And send patients home with a lot of homework. But in the long run, it's the correct way of doing it because you have a better outcome that way. Here's sort of a complex, the tear film is really an organ. It has an oil layer, it has this water layer, which has vitamins, it has growth factors, it has antimicrobials. There's like 3,000 proteins in a healthy, natural tear film. It's not just water. And there's a mucus layer that helps it all stick to the ocular surface. So if any of those layers are out of balance, you get what we call dry eye disease. Well, the treatment strategies are many, from your over-the-counter artificial tears, which are my least favorite treatment, because they're artificial, they don't have all that good stuff in them. But they're okay. Preservative-free artificial tears are what I tell my patients to use. And there's a lot of other strategies. I'm just going to touch on some of the big ones, but that's a whole other 2-day lecture if we were going to do the details of each one. But inflammation is a big part of dry eye disease. There's a lot of anti-inflammatories on the market. You may have heard of Restasis. You may have heard of Xiidra. You may have heard of Cequa. There's a new one called Vivi. These are all sort of anti-inflammatories that you can take that in the long term improve the inflammation of the tear film. Sometimes I'll use steroids if patients have severe flares of dry eye disease. So these are all different drops that we'll use in the preoperative setting. There are lid margin disease treatments. So I tell everybody at least do hot compresses at home. There are these nice masks that you can either plug into the wall and they heat up, or you can microwave and they heat up. You put that on for 5 to 10 minutes once a day. They improve the oil glands. They melt that butter. They turn it into oil so that it starts to express and starts to move. There's different in-office lid treatments that we can do to get that oil gland moving as well. One of those was what you saw where we heated it up and then I came in with a paddle and squeezed out that oil. There's also automated version called LipiFlow where we hook the patient up and there's a 12-minute massage, heat and massage. It's all heat and squeeze. Heat and squeeze out that trapped butter to get those oil glands to flow better. So these are all procedural techniques we have available in the office. Sometimes I'll say, we should really do one of these things first before wait a month, let the oils improve, and then do the cataract surgery. Omega-3 fatty acid supplements, fish oils. These are really good also, they improve, and some are better than others. So ask me and I'll tell you the ones that are better than others. I'm not a fan of the Costco brand because you need to take a lot to get the same bioavailability. For some severe dry eye patients, I do something called autologous serum drops. These are drops we make out of the patient's own blood. So there's a company, they come out, they send a phlebotomist to your house, they draw your blood, the lab spins it down, gets rid of the red blood cells and takes the plasma portion or the serum and bottles it into all of these little vials, eyedropper bottles. They send you a batch, they're good in your freezer for 6 months. You use them on the eye like an eye drop, and these serum drops have more of the good stuff. It's like chicken soup for the eyes. It's got the good stuff in there that helps, the growth factors and the vitamins that really helps the ocular surface improve. Better than artificial tears, but it's a hassle. You have to have a blood draw. It's not covered by the insurance. So there's a cost to them as well. But I use that for some severe dry eye patients. There's a new thing, you guys may have seen the commercial for this nasal spray. Have you guys seen this nasal spray? Yeah. So it's very interesting. It's Varanaclean nasal spray. And what you do is you sort of spray it on the lower part of the nose where the nerve ending of the trigeminal nerve is. It triggers that nerve, which sends a feedback loop to your brain and to the lacrimal functional unit to produce your own good tear. So it increases your own tear production. Now, the main side effect of this is sneezing. So I tell you, you're going to sneeze. You have to spray it sort of the lower part. It's not sprayed way up into your sinuses. You only need it at the lower part of your nose. And it triggers that. And the studies have shown that using this twice a day will improve everything on dry eyes over a month or two. Some people don't mind the sneezing. Some people are bothered by it. The sneezing does tend to decrease over time. Some patients who have arthritis and can't use drops, this is a great alternative. Some patients who are already on maybe glaucoma drops and don't want to add on more drops, this is a great alternative. Sometimes women who wear a lot of makeup and they don't want to in the middle of the day be using, drops in their eyes, this is another alternative. So this works nicely as well. What's new? So there's 2 new things in the dry eye market. One is called MIBO, which is perfluorohexyloctane. It's a non-water eye drop, which it kind of mimics the oil layer. It goes in there, creates a shield, prevents evaporation. This is new to the market. And then the last thing, and this is kind of gross, but part of the reason some of our oil glands get all clogged up and we have red crusty eyelids and blepharitis is mites. Really, really gross, but they nest there at the base of the lashes and create these little waxy sleeves around the base of the lashes. That's their nest. This is so common. I'm sure most of us in this room have some of this. It's part of the skin mites. We coexist with these little critters. The problem is when they overgrow, and I've seen this in some patients where they really overgrow and all of the lashes have these greasy sleeves. That's these mites growing in there, and they create inflammation. They're vectors for bacteria, and so they create crusting, eyelash itchiness, eyelid itchiness, redness, and they also give you dry eyes because they're creating constant inflammation around that area. Well, before recently, I would tell patients, well, you got to go home and you got to get this tea tree oil scrub, and you got to really scrub that twice a day, and it was such a hassle and so painful, most patients would just not do it or not do it well. Now we have a drop for this, and it's called Xdemvy, and it's interesting because it's a GABA chloride. It's specific to insects, and it goes into their nervous system and kills them from the inside out. And it's 100% safe for mammals. We're mammals, they're insects. So it's okay for our cells, but it kills the mites. And it completely, after their trials looked at using this medication twice a day, it's an eye drop. So an eye drop, you use it twice a day for 6 weeks, and it wipes them out. It's amazing. I love it. Anyway, so this is available now for patients that need it as well. All of these new drops, when they come out, the number one difficulty is insurance coverage. I hate it. It's like the one thing I wish I could just get what my patients need to them quickly. But oftentimes, insurance becomes an issue, and we have to jump through a lot of hoops. But we do it. We do it because that's how the system works. But there's a lot of good therapeutics now available for these things. So this is a lecture I give to other doctors in this field. I say a patient who is educated before cataract surgery about dry eye disease or ocular surface disease, including its impact on visual outcomes and the need to treat aggressively, is more likely to adhere to the recommended treatment regimen. So if you know the impact of it on cataract surgery, then most patients are saying, yes, I'll wait the extra month or two, get my dry eye improved, and then do cataract surgery, because it's so, so important. So again, multifaceted approach, and I always tell other doctors when I give this lecture, I say, don't turn the asymptomatic pre-op dry eye patient into a post-op symptomatic dry eye patient, because then you get blamed as the surgeon. But it's basically because the dry eye was there, nobody ever told the patient, you've got dry eyes, we got to treat it. So anyways, with that, I'm going to conclude my talking and turn it over to you all. I hope you enjoyed that, and I'm open for questions.
Thank you, Dr. Farid. All right, I'll be coming around the room now with your questions if you raise your hand.
Sure.
Do you use a different lens if you have a cataract in one eye but not in the other? I don't mean a cataract, I mean astigmatism in
Yes.
one eye and not the other.
Yes, if you have astigmatism in one eye and not the other, we'll treat it in the eye that has it. So I'm a perfectionist, so I say if you're doing cataract surgery, you take the opportunity to improve all of those. This is the opportunity to fix your astigmatism and fix your really get the quality vision you want. Yeah.
My second question is, my ophthalmologist told me that because I have thyroid disease, that it causes dry eye.
Yes, it does. Absolutely. So any autoimmune disease, thyroid disease, lupus, rheumatoid arthritis, Sjogren's, all of these give you worse dry eye. So we treat you more aggressively. Yeah. Doesn't mean you can't have cataract surgery. It just means we need to manage the dry eye appropriately. I think I saw one. Yes, go ahead.
Does cataract surgery increase sensitivity to light?
Great question. So the cataracts, when they've formed and have stayed around for a while, they actually turn a little yellowish brown. And so they're acting as internal sunglasses. And so if a patient has had cataract for like 5 to 10 years, their brain is used to almost having that diminished light. Now we take their cataract out, we put a clear lens in, and some patients will say, oh my gosh, I'm getting so much light in now, because that internal blockage of light is gone. So yes, some patients will get increased light sensitivity, and so I tell them, wear your sunglasses after surgery for a while, and then we start weaning them. You should wear sunglasses anyways, but there is that period of adjustment in some patients. Good
What
question.
about severe, where I understand the DMV will allow you to tint your auto?
Yeah. If it's very severe, sometimes patients bring in a little sheet for me, and I sign off on it that that's okay
For the
if it's
DMV?
needed. Yeah.
Thank you.
Okay.
Yes.
Dr. Farid,
Yes.
is there a subspecialty for people who already have an eye disease and need cataract surgery? For example, pseudoexfoliative syndrome and glaucoma, things like that. Do you need to get a specialist of a specialist, like more than a cataract
That's
surgeon?
a good question. So pseudoexfoliation syndrome can have just the syndrome, or you can have glaucoma from it as well. The syndrome itself, if you have a cataract surgeon who does complex surgery, we are very comfortable treating pseudoexfoliation syndrome. It makes the capsular bag a little unstable. If you have glaucoma as well, I always like to have a glaucoma specialist, not necessarily in the surgery, but managing the glaucoma part of your eye disease as well, and the intraocular pressures and so on. Yes.
You mentioned the omega-3. Do the arids, vitamins, help your eyes at all?
So there's different arids. Arids are good for macular degeneration, so they have higher dose of vitamin E, they have lutein, things like that. The higher omega-3 fatty acids, I think some of them might have some of that in there, the omega-3s, but the omega-3s are found, there's other manufacturers that make omega-3 fatty acids as well, separately.
So the arids type vitamins aren't really necessary?
They are if you have macular degeneration.
Okay.
That's the population where it's been shown to be helpful, yeah. Yes, ma'am.
Hi, thank you very much. Some other eye diseases, like mentioning macular degeneration. So if there are some beginnings of dry macular, just as there's beginnings of cataracts.
Sure.
You mentioned then some of the fancy lenses, et cetera, would not be good for somebody that is experiencing that.
So that's a great question. So if the macular degeneration is very mild, we actually do retinal scans. I actually look at those retinal scans myself, and if the macular degeneration is very mild and it's sort of outside of the macula, it's not really central under that central part of the vision, what we call the fovea, the foveal contour is normal. Sometimes there are certain lenses that will have a little more wiggle room. So it doesn't mean you have zero options. If the macular degeneration is advanced enough where there's changes, your retina specialist is seeing it, sometimes I'll talk to the retina specialist and say, what do you think? Can this patient have this type of lens, or is it better if we steer away from it? So depending on the severity of the macular degeneration, is when I determine, can we do a multifocal or maybe an extended depth of focus lens on those patients? Sometimes I do.
Okay, but does that include if it gets worse, though? Does macular get worse?
It can, the macular can get worse, but
Yeah.
once you have the lens in your eye and your brain is used to it, it doesn't matter after that point. But if you have advanced macular degeneration, and now we put in a lens with rings, will give you more distortions. But if you don't have the macular degeneration affecting your central vision yet, and your central vision is fine, we put the lens in, you actually do okay. But the question is it worth having a multifocal lens in there if your macular degeneration is bad enough? And sometimes the answer is no.
Do people who are allergic to or sensitive to synthetics ever react to the lenses?
great question. No, these are very, very inert lenses. They sit suspended in the center of the eye, so they're actually away from anything. They don't rub against anything. They're sort of suspended in this little hammock in the center of the eye. There's one group of patients that, they're children that have juvenile rheumatoid arthritis, that in textbooks there's some sensitivity to these lenses, but that's the only population that is, nobody else.
Yeah, thank you. If you have anterior basement membrane dystrophy, what is the downtime? How long is your vision blurry before you could work or drive or do basic things?
So the question is that anterior basement membrane dystrophy is a type of corneal dystrophy, and there's different types of corneal dystrophies. Similar to macular degeneration, depending on the severity of the corneal dystrophy, sometimes I'll avoid putting in these multifocal lenses because there's irregularities on the surface of the cornea. If the irregularities are severe, sometimes I'll even do a procedure in the office to clear the cornea of those irregularities, wait for it to normalize, and then do cataract surgery. In the milder forms, we just go ahead and do cataract surgery with a standard monofocal lens, and the recovery is very much the same. When you have these corneal dystrophies, sometimes you are at a little bit higher risk of erosions of the cornea, and so we'll have a discussion with the patient to make sure they're aware that that can happen, and we'll watch out for those things.
So the lens option is the monofocal, if you have that?
For most cases, not all. Again, similar to that, depends on the severity of the corneal dystrophy.
And then if I'm going to get my cornea scraped, what is the downtime before I can do normal things?
It's about a week.
A week.
It's about a week, yeah.
What are the consequences of getting two different lenses when you have two different cataract surgeries?
So sometimes I'll even plan to do a mix and match of lenses. Because remember, these lenses, sometimes some have great distance and intermediate, some have great intermediate and near. Sometimes I'll mix and match, depending on the patient and depending on the visual requirements. It's okay. I usually try to keep them in the same family. So if it's a manufacturer, I try to keep the same manufacturer of lens type in the eyes. But the brain is an amazing computer. It takes the images from the two eyes and turns them into one good image. And so it's okay to have two different types of lenses.
It doesn't confuse.
It doesn't. For most cases, it doesn't confuse, especially if it's planned. If it's unplanned, maybe a different doctor did your other surgery, and then a different doctor did another surgery and didn't really look to see what other lens was in the other eye, then you can have mismatches that might be more difficult to adjust to. But sometimes if it's planned preoperatively, like I'm going to maximize the benefits of these two lenses, and we have two eyes, so I can play with it a little bit and customize your vision that way, then those work out really nicely.
Doctor, are there patients,
Yes.
are there patients that are not good candidates for the laser cataract surgery?
Yes, some patients, if they don't dilate well, I don't laser necessarily. Yeah, there are some cases, mild cases, where I would say laser is not really going to benefit you. I don't think there's really a hard and fast contraindication, like, oh my God, if we do the laser, it's detrimental. Not really. We'll just shut down the parts of the laser we don't want. So sometimes I'll use the laser only for the incisions, or only for the astigmatism, or only for the lens softening. I have the power to actually program my laser to use the parts that I want.
Okay. Then on the quick question on the mono lens, I don't like the idea of taking glasses on and off. Can you get a progressive with a mono so that you can avoid that?
The progressive is the multifocal. There is no progressives like we have in
glasses.
glasses.
I'm talking about glasses.
Oh, yeah.
So,
you can get any, yes, absolutely. So can you get regular lenses, set them for distance, still wear a progressive so you don't have to take them on and off? Sure.
Yeah, okay, good.
Absolutely.
Okay, good. Thanks.
Absolutely, yeah.
Hi. I've had dry eyes since I can remember, and I've always done everything they told me with the scrubs and the heat and the omega-3s and Xiidra and Restasis and the whole business. I don't know that it's made a whole lot of difference. Yeah. My concern is, and I also had one of the treatments at Gavin Herbert, for the
LipiFlow?
Yeah, the LipiFlow too. Anyway, my concern is that, because I'm scheduled to go in actually on Monday to talk about the cataract surgery, I'm concerned that maybe the dry eye can't be treated to the point where the cataract surgery will be successful.
Yeah, great question. So we have a lot of patients like you, that really tough, challenging dry eye patients where we get them sort of better, but there's a point, and there are more therapeutic, as I mentioned, there's like 2 new things on the market and more coming, because this is still such an area where we don't have the perfect thing that treats everybody. We have, we attack the dry eye from different angles. We try to get it as best we can. Some patients, we get to a point where we're like, okay, this is as good as we're gonna get. Dry eye is a thing we're gonna have to deal with for your whole life. Let's go ahead with cataract surgery. And what we often do in cases like yours, we'll say, well, again, avoid a multifocal lens, maybe just do a monofocal lens, and then continue treating the dry eyes. And so it's, there is a point where we say, okay, this is as good as we're gonna get your dry eyes in some severe patients.
Worse after the cataract surgery?
Not if you're pre-treating, and you have a doctor who actually is addressing the dry eye, which it sounds like they are, then you're in good shape. Okay. Yeah. Yes.
I have a question. You mentioned the progressive. What if a patient has, say, trifocals, and they want to have glasses afterwards? So they have the monofocal cataract lens, and will that be any different, much different than what they had before with trifocals?
Yeah, so the reason you have trifocal is probably because there's a prescription up above.
Yeah.
And so, for example, you might come in and you were maybe a -7 and you have to wear these big, thick glasses. Well, when I put in the new lens, I'm not going to keep you -7. That's terrible. I want to at least get you close so that when you wake up, you can see the world. But then, it's still a monofocal lens. So you could still wear glasses or a progressive or a trifocal afterwards. You just won't, the prescription won't be as strong.
Yeah, but you still get the benefit of having, say, distant, medium, and close afterwards.
Yes, with the glasses.
Okay, thank you.
Yes, absolutely, sure.
With cataract surgery, is there any way that floaters can be impacted?
Floaters are the other bane of my existence. We don't have anything good for floaters. Floaters are it's the gel in the eye. And everybody gets floaters with age or the length of the eye. It's the gel pulls away from the back of the eye, takes these little fibrous rings with them. We see them as floaters. My husband has them, and he'll pat them and say, "Can't you do something about this?" I'm like, "No, not really. You can't. We don't have anything great to take care of floaters." But I've had some patients where it's so severe, we'll actually have our retina colleagues go in and do a floaterectomy or a vitrectomy to take out the gel in the eye, which is kind of a severe, it's a big surgery for floaters, but sometimes the floaters can be that severe where it's worth it for some patients. Yeah, I know. But floaters do thin out over time, because with age, the gel gets more fluidic and the floaters diminish with age, so. Yes.
Hi there. Unique situation, a 6th cranial nerve palsy. Would that complicate a cataract surgery? The palsy was never, after all intensive purposes, looked at from many different doctors, never.
And is there double vision still?
The cataract is in the eye that had, I don't know, I'm
Okay, I can talk about that. So 6th nerve palsy is a palsy to one of the muscles that moves the eye, right? Or we have 6 muscles that move the eye up, down, left, right.
Like a normal dioptic, is that what you would say? A normal
prism diopter. So again, a 6th nerve palsy, it affects the eye rotating outwards. So right, if you have an acute 6th nerve palsy from a little stroke, or diabetic sometimes will get a little stroke to that nerve, then the eye doesn't move out well, right, and so you get double vision.
6 months, right?
Right, you get double vision, and so double vision is sometimes, if the double vision persists, you're central when you're looking straight and you have double vision. Sometimes the optometrist will put prisms in your glasses to correct the image so your double vision goes away.
Right.
So patients who come in and who have double vision because their eyes are not lined up, whether it's from a sixth nerve palsy or otherwise, will likely still need prisms in glasses after cataract surgery. So we can correct the acuity of the eye, but we're not touching the muscles of the eye. So if the eye is not moving well, that's not my surgery won't fix that. That's going to be either prisms in glasses, or we have muscle strabismus surgeons that deal with the muscles of the eyes.
So if that has corrected itself and there isn't what I would say a double vision anymore, it's just no vision because of the cataract,
then we just go ahead with cataract.
Cataract would be.
We can just do it as normal.
Okay.
Yeah.
All right, thank you.
Can cataracts cause higher than normal eye pressure? And if so, does it get back to where it needs to be after the surgery usually?
Sometimes if the anatomy of the eye is very small and the cataract is getting fat, it can actually crowd the eye and cause the pressure to go up. So in those cases, even if the vision is not bad, I'll say, you know what, we should take out your cataract because you're going to get glaucoma if we don't. So there is a subset of population.
Then it gets better after
Yeah.
the surgery? Good, thanks.
Yes.
Hello. Two quick questions. What would you suggest if an ophthalmologist I've just seen suggested flaxseed oil instead of the fish oil, and what to look for?
And some vegans don't want to take fish oils, so flaxseed oil also helps with improved oils and omega-3s.
Is there something to look for, though? What type of, like within the flaxseed market?
Family?
Yeah, or brand, or certain omega-3s?
Yeah. So actually, there is a company called PRN Omega Health.
Mm-hmm.
They make fish oils, but they also make a vegan omega-3, and I think they use flaxseed. That's the one I use, actually, myself. It has the best bioavailability. I have no financial interest. The company does not pay me, I promise you. But that has a really great bioavailability. Are there other companies that have good ones too? Probably. I don't know. So sometimes I let patients do their own research, but that's good. Maybe we'll all go and look that up after your question.
Can you repeat that? The PRN?
PRN Omega Health.
Oh, PRN Omega
It's actually
Health.
online, PRN Omega Health.
Okay.
.com.
Thank you.
Yeah.
The other question is, if I've seen an ophthalmologist that did not seem concerned with dry eye and another did,
Go with the one that did.
Yeah, I mean, it really opened my eyes when I heard that, but he was also the one recommending the multifocal with the 3, and I was thinking all along I would do monovision because that's how I used to wear my contacts, and the comment was that with monovision, I'd love to hear your thoughts, he wouldn't do monovision, or he doesn't like to do it because something could happen to one of your eyes and now you have only distance or near in one eye if something happens to the other eye versus having full vision in one eye. Yeah, right.
So interestingly, monovision, what you're describing, is when one eye's distance, one eye's near. Some people have done this in their contact lenses in the past. Their brain is used to it. They like it. Monovision patients actually have excellent brains. Why? Because you've adapted to this really weird one eye distance, one eye near, and your brain is sort of tolerated. If you picture it, when you see an image and you have monovision, you have one in-focus image and one out-of-focus image on your brain at all times, and your brain has learned to ignore the out-of-focus image. Right. So you have been seeing halos all along and ignored them. So monovision patients actually do very well with multifocal lens technology because their brains are already very used to tuning out halos. And now you have the benefit of having full range of vision in both eyes. So I do believe that monovision patients do actually very well with multifocal lenses. But I think, if it's your choice, or if you don't want multifocal, maybe for whatever other reason, then monovision, you can absolutely do that after cataract surgery, but you would also probably do very well with multifocal technology. Jump in, thank you.
Do antihistamines taken on a daily basis, year-long, contribute to dry eyes?
Yes. Yes, oral antihistamines will give you, they are very drying. Okay. Yeah.
I have a question about, do you have to have laser to have a multifocal lens, or can you have just a regular blade surgery and get the multifocal lens? Is there a correlation with that?
That's a great question. Do you absolutely have to have the laser if you're getting multifocal lenses? The short answer is no, you don't absolutely have to have the laser, but I actually do like to do the laser for all my multifocal lenses because the laser helps with centration of the lens within the capsule. It centers that capsulotomy right over your visual axis. And remember, the multifocal lens has those rings. You really want that centered on your visual axis. And so it really fine-tunes that centration, and it also treats a little bit of astigmatism. So it's just better if you're going to if you're paying for the multifocal lens, I always throw the laser in because I'm like, if we're gonna go for the Ferrari, let's go for the Ferrari. Let's not skimp out on the wheels.
If you have a retinal tear that's been repaired, does that affect anything at all?
Peripheral retinal tears in the past that have been taken care of really don't impact it at cataract surgery at all, or our decision for a lens.
And one more question. I can see with reading glasses just perfectly, but I've had 3 different optometrists try and make me glasses to see far, and it's always blurry. Is that common with cataracts?
It might be cataracts. It may also be dry eyes. So if you're going into, some people say, I go into my optometrist, I'm good, I see it there, and then I go home and it doesn't work well, or, it's fluctuating. Sometimes that's the tear film that's not doing well. But it could also be an early cataract too. Yeah. Right, yes.
Could you talk a little bit about what putting amniotic membranes into your eyes do and using drops made out of amniotic fluid?
Yes. Okay, so now you're delving into more dry eye treatment. So there is something called amniotic membrane that comes in this contact lens almost, or in drops. It's basically from around the placenta. These are donated placentas, and they take the amnion from around the baby. They're freeze processed tissue, so they're all clean and healthy. And we use those in very, very severe forms. I prefer autologous serum, the blood serum of your own blood, over amniotic membrane drops, but they work about equally in my hands from where I've seen it. The contact lens version I'll use if you're having erosions of the cornea, so only in very, very severe forms of corneal disease.
25 years ago, from what I remember, the astigmatism with LASIK was taken out of both of my eyes, and I've had monovision since. And I think, so what happens now if you need cataract surgery? Do you do it in both eyes? Because
so I'll tell you
I'm fine.
What I recommend now for all of my cataract patients that come in who have had LASIK, myself included, my sister included, is I recommend the light adjustable lens. Because the light adjustable lens, when you've had LASIK, the traditional formulas we use to determine the power of the lens that goes into your eye, they don't work well. And so sometimes we'll come in and we'll try to guesstimate the correct power. Sometimes you may end up being a little more nearsighted or a little more farsighted than what we planned, and that's because the LASIK threw off our calculations. But the light adjustable lens, it doesn't matter if our calculations are a little off, because we can adjust the power afterwards and get you tuned in perfectly. So that's what I would do.
Thank you.
Yeah.
Okay, we've got a couple more questions, and then we will wrap up. We're down here first.
Thank you for being here. Just a quick question about the autologous serum drops. I'm asking for my own edification, not so much implying do this, but I do PRP, but for orthopedic conditions.
Yes.
Is it literally just the serum after centrifugation?
So PRP is better, but we just don't have a company that can be. So PRP is plasma enriched protein. So there's some study. I don't actually know if there's a head-to-head looking at serum versus PRP on the eyes, but I've had some patients who have access to somebody who can make them PRP. And it works really nicely on the severe corneal dry eyes. Serum works similarly, but I think PRP might have a little edge up. But we just don't, we have a quick and easy company that comes out and does our serum for us, and they give us really good products, so that's what we're using.
That's fantastic, thank you. Yes, we're pioneering the regenerative medicine aspect, so that's great, thank you.
Sure.
One last question. You said that there's some cases where between 6 months to 6 years, there is that little cloud.
Yes.
It can easily be taken out?
Easily. It's a 1 to 2 minute in-office laser procedure. And you only need that done once. It's called a YAG capsulotomy, and it clears that hazy membrane after your cataract surgery.
But in order to figure out if that's exactly what I need, what do I do? Where do I?
Just make an appointment with either your cataract surgeon or any other cataract surgeon. They'll be able to see it right away.
Oh, so it's the definite thing. It's not, okay.
It's very obvious.
Thank you.
Yes, I think there's one more question there. Should we?
Oh. Conga's coming around.
Let me help you. Hi, can you tell me how long do the lenses last once you put them in?
Forever.
All right, good answer.
Okay, and with that.
Thank you. I have one question. If we all have mites under our lashes, where do they go if we take the drops?
They die and they get washed off in the tears.
Oh, okay, thank you. We will have this up on our website, so if you want to refresh your memories. And our next meeting will be the last Monday of February. We'll be talking about women's heart health.